Welcome to the SIBO Doctor Podcast, hosted by Dr. Nirala Jacoby. Medical experts join us to discuss functional digestive disorders, clinical practice and research as it relates to SIBO and associated conditions. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. Head over to thesibodoctor.com and sign up to the SIBO Mastery Program and take your SIBO knowledge to expert level. If you're a patient, you can sign up to the SIBO Success Plan and beat SIBO for good. Please note, this podcast series is not intended to diagnose or treat medical conditions. Ask your doctor before initiating any new treatments. And now, over to Dr. Jacoby and the latest episode of the SIBO Doctor Podcast.
Welcome to the first episode of the SIBO Doctor Podcast for 2024. Longtime listeners of this podcast have heard me mention the role of hydrogen sulfide in SIBO, IBS, and inflammatory bowel disease. And it's a really fascinating topic because hydrogen sulfide produced in low doses, either by bacteria or by our own cells, can be quite beneficial, but in high amounts, it's very detrimental to the gut and can cause fairly severe symptoms. In episode 20, I started the conversation about hydrogen sulfide and SIBO in my interview with Dr. Greg Nye, and I recently went deeper into the biochemical pathways of hydrogen sulfide and the implications of sulfur sensitivities with Dr. Stephanie Seneff in episode 101. I'm now circling back to discuss IBS treatment using high-dose sulfur with Dr. Kathleen Janelle. Dr. Kathleen Janelle has been practicing medicine for over 25 years. She's a graduate of Bastyr Medical School. Her and I are both actually graduates of the class of 1998, and she has a degree in biochemistry from the University of British Columbia. In New England, she completed a residency and associate positions in pediatrics and primary care. Over the past decades, Dr. Janelle has developed and refined a unique treatment approach for digestive disorders. She has used this therapy for patients around the country and around the world to help eliminate symptoms of abdominal pain, diarrhea, constipation, and the gas and bloating of IBS and SIBO. Welcome to the podcast, Dr. Janelle. So great to have you, finally.
Thank you. So good to be here.
You and I were in the same class in our medical school, Bastyr University, class of 1998, and it's amazing to have you on my podcast 25 years later. And both of us are IBS specialists and functional digestive disorders. And the reason I wanted to have a conversation with you is because you have a very unique protocol with which you treat SIBO and IBS, which involves high doses of sulfur. Can you start the conversation about this protocol and how you discovered it?
Sure, yeah. It was a personal experience that I had. So you don't know this because it wasn't something I was talking about, but all during the time when I was in medical school, I was having this issue. And the issue was every single day around noon, regardless of what I ate or didn't eat, or even if I just drank water, all of a sudden my stomach would distend uncomfortably, and it would be like that for the rest of the day. So I don't know if you noticed during those times, but I was really thin, and one of the reasons I was really thin was because I really didn't know what to eat to stop this from happening, and I was so full usually when this happened that it was hard to go home and have a regular dinner. So this went on, and because, obviously I was in naturopathic medical school, I was learning all the things I could do. So I did all those things. I saw naturopaths, many of them, and I did all of the things that we would normally do during this time. So taking digestive support and enzymes and betaine, and taking antimicrobials that were herbal, and taking antimicrobials that were fungal, and taking homeopathics, and changing my diet up, and what else? Prescription antifungals. So tons of stuff. I feel like I turned over every stone. And one day, and this was after graduation and after my residency, I was talking to a friend who told me about this compounding pharmacist who was using high dose sulfur. And I thought it sounded crazy. I thought, well, what is that going to do? So I talked to this compounding pharmacist and asked her that, and she said, well, it's an antifungal and it's an antimicrobial, so it's going to get in there and clean things up and help with repair, but you have to take enough of it, and you have to manage any kind of problems that might happen along the way. So I still thought it was an odd thing to do for this symptom, but I tried everything else. What's the harm in trying it? So I tried it, and I got 4 weeks into this 8-week protocol that she told me to do, and my symptoms resolved, and they never came back. They've been gone for the last 20 years. So that's when I started using it for my patients. Anyone who came in with any of those symptoms, I would start using it for them. And in the background, the whole SIBO thing was kind of going on, and I was noticing it, but I wasn't really going down the same trajectory because this was working so well for me. So I just continued on with it.
Absolutely fascinating. So before we go into specifically what the protocol is, why? Because I didn't know that sulfur can be used also as an antimicrobial. How does that work?
Sulfur is able to bind to the receptors of certain microbial species and stop them from adhering to the host. So that's one way. And I wonder if I have that open. That's one of the main ways. Most of the work around the antimicrobial nature of sulfur has been done on sulfur nanoparticles in sulfur thiosulfate, and it's been found to be antimicrobial, like in the petri dish. And I'm not sure if that's the same mechanism as the receptor binding or something else, but they've proven antimicrobial properties around staph epidermidis and some of the skin organisms, as well as, I'm going to pull up my PowerPoint because I know it's on there. A couple other species which we would find in the gut. So that's definitely relevant to what we're talking about, not so much the skin stuff.
Well, while you're looking for that, just to kind of update the listener to some of the previous conversations I've had about sulfur with other sulfur experts like Greg Nye and Dr. Stephanie Seneff. This whole issue of sulfur has been a huge, interesting topic, and I'm sort of approaching it from all different angles because, with SIBO, one of the causes of SIBO can be an overgrowth of hydrogen sulfide producers like Fusobacterium and sulfur-reducing bacteria, which is always very confusing to listeners. It's not that's not reducing sulfur. It's actually a chemical term. So it's about organisms. SRBs, or sulfur-reducing bacteria, are organisms that produce hydrogen sulfide, like Desulfur Vibrio and Bilophila, and there are others. And so we usually, our approach has been to avoid sulfur for a period of time and to potentially treat hydrogen sulfide producing organisms with things like oregano oil and so forth. And I have to say it can be really effective, but this whole approach that you have is a completely, 180 from that. So this is one of the reasons I've been so fascinated by this, and I'm glad you are going to elucidate what actually is going on here with all that.
For sure. So I found the slide. It was against Staph aureus and actually the E. coli species 0157H7 as well. In the same study, they found it effective. This is now in the fungal category, Candida, and also Aspergillus, a mold, not a yeast, but a mold.
Okay, that's really good. So this is just elemental sulfur that was being used, or for these bacterial
in this
overgrowths?
Particular study, they used sulfur nanoparticles, and they used the best sulfur nanoparticles and thiosulfate. They also used elemental sulfur, some sodium metabisulfate, which had some activity, but not as good as the first two.
So, when we think about the hydrogen sulfide producers, and there is some thought, and I've talked about it with these other speakers before, about that the body might be upregulating its need for sulfur by upregulating these sulfur-reducing bacteria. Is that what's happening, do you think? Or do you, that
I really
when you
do.
then give when you then give sulfur, that things kind of calm down?
Yeah, it's like you're able to create a new homeostasis or balance in the body because it gets what it needs. And I sort of worked backwards, right? I went from, okay, this is working so well for so many people and it's so easy. Why? And that's when I started finding the research from Dr. Stephanie Seneff and, reading some of the other material that's out there. And Dr. Seneff, her main proposition is that sulfur deficiency is ubiquitous. It's the most common nutrient deficiency that you've never heard of, and that's linked to the use of glyphosate in the soils, which impacts the soil microbiome, right? So anything that has the pathway that glyphosate will interfere with and kill the organism with is going to die. And when you look at studies of wetland plots where they spray it with glyphosate and then they see how fast can this glyphosate dissipate, and that's usually because some bacteria are picking it up. The best dissipation rates, up to 90%, are done in wetland plots that have a high degree of sulfur oxidizing bacteria. Those are the ones that have to take the elemental sulfur, oxidize it to sulfate, because that's the only form that the plants can take it up in, and then change it to whatever their plant version might be of that for their growth. So that's the first problem, is the soil microbiome is no longer able to function at that capacity. And then if you look at our microbiome, greater than 50% of our internal microbiome has the shikimate pathway. So as we're being exposed to glyphosate, we are losing a lot of our species, and specifically the Lactobacillus and Bifidobacter. So that allows for commensal overgrowth of, commensal or pathogenic overgrowth. And I think that's one of the reasons we're seeing a lot of SIBO, is because of that particular problem. We're clearing out space and other organisms are allowed to take over. And then you couple that with the fact that we're not able to, those sulfur oxidizing bacteria are not able to take the plant-based sulfur, make it into sulfate that can dissipate into our bloodstream and feed us. So that there's a back door, and that's the hydrogen sulfide is the back door. Sulfate reducing bacteria increase in their number. We get more hydrogen sulfide that can easily diffuse into the bloodstream, go to the brain and be converted to sulfate. Not a perfect system, but it might be a necessary system.
And there's also a lot of sulfur deficiencies in things like connective tissue disorders, right? In terms of its use for connective tissue and all that. So sulfur deficiency is what you think is one of the most common deficiencies, and it results often in digestive complaints.
Exactly, and weakness, so in terms of sulfur, we don't store it, right? Like most minerals, not most minerals, let's say calcium. Calcium, we store it in the bones. So when our body needs calcium for something, we're going to bring it out of the bone and use it. When we haven't too much of it, we're going to pack it back in there. But for sulfur, we need a daily requirement. We need between 850 to 1,500 milligrams a day. And whatever we don't use is excreted. It's turned into sulfate and it's excreted through the urine. So we need that constant intake of the sulfur. in order to maintain everything. The way that it functions in a structural component in our bodies is, people are really into collagen right now. Well, I believe the rate limiting step of collagen formation is really the sulfur. So if you give people sulfur, then they can make their own collagen from that using, the materials in their body.
So your approach really echoes that of Dr. Seneff, who thinks that we're all B12 and sulfur deficient, basically because of the very widespread use of glyphosate, which is, of course, the most common ingredient in Roundup. For those of you listening, so maybe it would be great if because you mentioned that you could potentially talk about a case, just to kind of illustrate how you approach a case and how you resolve some of these common digestive disorders successfully using your protocol. And maybe you can share a little bit about what your protocol is in terms of high dose sulfur.
For sure. I'm going to read first of all a note that I got, and I'm getting a lot of these, like almost a day, every few times a week. I'll get something like on Instagram or, one of the social networking sites where someone will reach out to me and say, "Oh my gosh, the needle finally moved," And so here's one that I don't know the name of the person. But she says, "I did notice a huge relief from the GI Janelle 1 powder, which is my version of the sulfur. I put a few other things in there. It's a combo of MSM, marshmallow root, slippery elm, and acacia, and it works. This was the first thing I've ever tried for SIBO that even slightly moved the needle. My doctor recommended it to me, and now I'm such an advocate." So that's something that I'm hearing a lot more of all the time as this information gets out there, which makes me really happy because I would much rather people do a non-antibiotic treatment, a non-prescription antibiotic treatment for this condition. And then the one main reason why I started speaking out about this was because of this particular man who is 68, and he lives in Washington State, so he has access to any like functional doctor, naturopath that he wants. When he was a teenager, he started having symptoms, and his symptoms were daily gas and bloating, kind of like what I was having. And so he'd followed all these different SIBO protocols. He'd been to see many doctors and many different nutritionists. He'd done every diet on the map. He'd even done the low sulfur diet, elemental, SIBO, FODMAP. Pretty much everything. He's taken all the supplements. He took prescription antibiotics and antifungals, and nothing changed. He had the same symptoms day after day. So when I saw him, he'd had at that point 40 years of treatment and diagnosis. And I started him on the GI1 powder, which is the high dose sulfur. So we started a low dose. I usually start a low dose and titrate people up, but this guy was just like, "Give me the full dose. I'm going in full speed." So I said, "Sure, if it's up to you, if that's what you want." So he started taking the 30 grams a day from day one.
And that's 30 grams of MSM, basically?
Yeah, 30 grams of MSM, yeah. So I talked to him, and that's unusual for someone. There's only been a few people over the course of the last 20 years that, I've been okay with doing that. So we had a 4-week follow-up appointment, and he said that for the first time in 40 years, his symptoms were gone.
Wow.
And he continued on, finished the 8-week protocol of the 30 grams a day, and that was 5 years ago, and his symptoms have never come back. So when I talked to him at that, sort of end of our relationship, 8-week call, it was a telemed call. He said, why are people not doing this? Why do you live here and everyone else lives here, but this is the first time that I've heard of this? So I decided, you know what? I guess I better speak out about this because people need to know. And if you want to do one more fun one, I love this because it was actually a referral from you. You might not remember. I'm sure there's a lot of people that go through your door.
I do sometimes, I like to have people boots on the ground, and not virtual, and just refer somebody who's in the state that where I have a good trusted practitioner, So I'm glad that
Yeah.
she reached out.
Yeah, it was awesome. This is a family that I think they met you at a conference when you were speaking here. And this was back in 2017. So they came in to see me, and these people have been through a lot prior to seeing me. So they actually had 2 different SIBO tests and 2 different courses of treatment. Both involved doing Xifaxan, so a course of Xifaxan, rifaximin, and they followed the low-fat MAP diet one time. The other time they followed the, what diet was that? Xifaxan, low-fat MAP diet, and then I think it was, the specific carbohydrate diet. And following their first treatment with Xifaxan and the limitations with the diet, they were okay for a little bit. Then they started expanding their diet to add their carbohydrates back in. All the symptoms came back. So they went back and did a second course of Xifaxan and did the next diet, and then the same thing happened. They were good for a little while. They started adding their foods back in, and then their symptoms came back. And I see that a lot with people, a lot. So they had these 2 restrictive diets, 2 courses, and their symptoms when they came in to see me were abdominal pain and daily bloating. So this is a family of 4, mother and 3 sons, and all they could eat at that time were beef, fish, lettuce, carrots, rice, and berries. That was their entire diet. If they strayed from that diet, they were in a lot of pain. And a lot of bloating. So that's what they were doing. So I basically kept them on that diet just because it takes out my core inflammatory foods. We can get back to this later, but there's a overlap between the foods I consider inflammatory for people that cause an underlying problem so that SIBO comes back, and the overlap is with some of the high dose sulfur foods.
Okay,
So
I
I'm
definitely
taking
want to
them
know
out of the
that.
diet.
Yeah.
Yeah,
Definitely
I'm
want.
taking, yeah. So there's different reasons we're taking them out, and getting some good resolution for people. So we can circle back. But so I kept them on that diet, didn't make any changes, and I sent them away with the half dose. I told them to titrate up to the half dose, which is 15 grams a day, 15 grams a day, 1,500 milligrams a day. And then I saw them in a 4-week period of time. They had less gas, less bloating, less abdominal pain, and their stools were more regular. So that was 4 weeks later. And honestly, Dr. Jacoby, I expect this. I expect to send people away that get to that like half dose point and come back and say things are getting better. Nothing's 100%. I'd say maybe 15% of the time, they become more of a head scratcher, more of a like, we're going to delve into this a little bit deeper. But 85% of the time, this is what I see. So then I sent them away.
Oh, sorry. You weren't done with it. Yep. Okay.
Yeah. So then I sent them away again. I had them titrate up to the 30-gram dose. They kept that for 4 weeks, and they were feeling so good over the course of the 4 weeks that they added back into their diet legumes, dairy, and wheat. No symptoms returning. And when they completed the 8 weeks, we talked, and they had no gas, no bloating, no abdominal pain. Their stools were regular. And so the course of time after that, they added back everything. So they were doing sugar and cruciferous vegetables and all the rest of it, and they were fine. And then my last check-in with them was this year. So 6 years ago, not one of them has had a symptom relapse.
Oh, fantastic. So do you, for those listeners, I'm always very careful to say, look, it's great that people are getting good results with it, but do you differentiate between different conditions? Like, do you test for SIBO, or do you do any microbial workup, or do you give it based on symptoms?
So I start with a symptom picture. If someone comes in and they have bloating, gassy bloating, and it can either be associated with pain or not, then this is where I'll start.
And
if they come in,
Oh, sorry.
Just if they come in and they have any other, more predominant symptoms, then yes, I might do some more testing and some more discovery before we go ahead with any treatment.
Okay, because I just have a lot of in a way, specific questions, because in my line of work, where we see such advanced cases, that have like your first patient that has gone through the ringer in terms of treatment and workup and still nothing is working. Those are the patients that I see. So, there is always a level of sensitivity, I find, that is sometimes difficult to overcome. I have people that are severely reactive to any form of sulfur, where we have to really do all this other work with pathways and SNPs and all that. That was discussed with Dr. Seneff and Dr. Nye. So listeners, you can go back in the archives and listen to that. So that really helped them to improve their sulfur tolerance. Do you see any level of that?
Of sulfur intolerance. What kind of symptoms do you get that are manifesting as sulfur intolerance?
So severe skin rashes, and I'm familiar with the Herx concept, and we go very slowly. Also, very severe digestive symptoms, very severe gas, and it's feeding into the hydrogen sulfide production. The inflammatory nature of hydrogen sulfide itself, and so in many cases that is then improved by treating hydrogen sulfide producers and then slowly reintroducing sulfur foods, So I just wondered, and many of the practitioners that I've talked to about hydrogen sulfide have a similar experience, and I'm just curious what your experience is with that, with this level of intolerance.
I do see it. Maybe not as frequently, because again, it sounds like your patient population is very much more advanced in their symptoms and length of time with the symptoms. So I'm not dealing with that piece of it. But I have seen it a handful of times, the skin rash piece. Usually I do a lot of hand holding at that point, because I really know that if we can get these levels up, then we can get you some resolution. So I'll do pinch doses. I'll have someone who's super sensitive just put a pinch of a dose of the treatment in water, drink that either all at once or throughout the day, and we'll very, very gradually increase. I've got one patient I'm doing that with right now. I think she's in Virginia, and it's just a very slow process. There's someone else that comes to mind when we did that very slow process of pinch dosing increase. Took her 2 years to get to the full dose, but her symptoms did resolve once she got up there. I think she forgot almost, how bad she had felt.
They always do.
Right, that's why we take the notes.
Yes, that's right. So what you're saying, correct me if I'm hearing this wrong, but you're saying that pretty much all bloating has some root in sulfur deficiency, or is it just a specific type? For you, the patients that you're seeing pretty much all resolve with their bloating, because this is huge news for people that have very incessant bloating. And I have people that I treat for SIBO that are fine, they're cleared, it's all good. They may or may not get a relapse, but their bloating definitely resolves. And then there are people that continue to have symptoms, and then I look deeper into microbiome issues, digestive issues, etc. We all do that. So, but what you're saying, which is pretty big, that all bloating has some element of sulfur deficiency. Is that correct?
I wouldn't say all, but what I would say is that the sulfur is a strong enough antimicrobial and antifungal to take care of a lot of those fermentation problems in people. I've come to believe that in terms of the hydrogen sulfide patients, and this is based on clinical experience, right? So if I go in there with the sulfur and then we clean everything up, but this person has had, a methane or, a plain hydrogen elevation in their breath test previously, that goes away too, right? So the bloating symptoms, and it's not like I don't retest all the time. Not everyone wants to, do that. So either we base it on symptoms and say, okay, well, we're done here, or retesting, but things resolve. And that's what I'm saying about it may be partly due to that compensation by the body needing more sulfur, producing or growing more of those sulfur-reducing bacteria. But it also might be a general homeostasis within the microbiome diversity that's allowed to actually proliferate once you give the body what it needs in terms of that sulfur component.
I was just reading a study about, because I'm big, my big fascination is anything microbiome, because to me that's where it's at, whether it's in the small intestine or the large intestine, and what we're really losing with our modern lifestyle, diet, medications is these connections between bacterial communities where one bacteria might produce a metabolite that's consumed by another, sort of cross-feeding type of situation. I was reading this study that one of the big hydrogen sulfide consumers is actually Roseburia intestinalis, which is a big, might be a big missing piece in somebody that has hydrogen sulfide overproduction, only because there isn't anyone on the other end consuming it. And so this is why I'm a big proponent of normalizing and improving microbial diversity and reestablishing these bacterial communities and networks, which is so important when you think about it. And I wonder if that has if that also impacts if sulfur also impacts the reestablishment of some of these communities.
I don't think it cannot do that because of how permanent the responses can be. And by permanent, I mean these people can go out and, just like the family that I just talked about, they can go out and just reintroduce the healthy foods and not have a limited diet and go about, including sugar, which the young people in that family were pretty happy about. The mom, not so much. But, nothing was really having them have a setback at that point. There was something else I was going to say about that. What was it? Can't remember.
I'm just to clarify to the listener, we both have worked so much with gut patients that it's always, I'm always very cautious before I say, okay, everybody that's bloated, just try sulfur. Because for me, there are different reasons why people get bloated. You could be bloated because you're not digesting your food right. You're lacking hydrochloric acid, you're lacking enzymes. To me, that's more of a deficiency of that substance rather than sulfur. So it's super fascinating for me to hear that it's almost without fail is what I'm hearing, that you do get improvement in your patient base anyways.
Yeah, and I like to start with it because what I can do is, if we don't have complete resolution, then I can go back in and look at those other things. Okay, so maybe you do need some more digestive support. Maybe you do need some more hydrochloric acid. And maybe we do need, like, the biggest thing I go in with afterwards is antifungals. Because a lot of the people that I'm seeing, they've already been through several courses of Xifaxan. They don't need another antibiotic, and especially if there hasn't been any kind of shift in either symptoms or testing in terms of post-antibiotic use, right? So I will typically go in with an antifungal afterwards and try my best to try and determine what is it that we're dealing with, because that the fungal or the yeast species, they're pretty hard to detect sometimes. You're lucky if you get them out in a stool sample. They might be in the small intestine, in which case, how are you going to get them out? How are you going to get a sample to test sensitivity on? You're not.
Yeah,
so
what is I usually do the organic acid tests, look for arabinose and those. Do you find those fairly accurate in your practice?
Well, there's something.
Mm.
You know, they're at least something, and they at least differentiate between Candida and a fungal species. But the latest one that I've been doing more of is the mycotoxin
Mm.
antibody panel. Um,
Is that real-time labs
eh,
or so?
no, I don't use real time. I use. We're allowed to talk about stuff here, huh?
Well, labs, yes, more or less, just
Okay.
from a practitioner to a practitioner, you know.
Okay. So yeah, I use my mycotoxin, and I met that particular lab director a year ago, and he started talking about, because I had been doing a little bit of mold work with people as well, because there's always that overlap between fungal here,
Huge.
fungal there,
Mm.
right? So he was telling me about, well, people, it's not just like a mycotoxin inhalation problem that we have; it's a spore inhalation and a spore ingestion. And there was a ENT doctor who took his chronic sinusitis patients and going in and cleaning it out and throwing everything away, he sent it for culture. So when he cultured out what he cleaned out from the sinuses from these chronic patients, 95% of them had mold growing in their sinuses,
Mm. That's like
right?
that
And
famous,
so,
that Mayo Clinic, right? Also said that 95% of most chronic sinusitis is actually fungal in origin. That was
correct,
revolutionary, like when I read that 20 years ago or so. But
correct.
yeah, so do you find, like, what's your success rate with sulfur using? I mean, I'm sure you do other things, but that seems like an integral component of your treatment protocol is sulfur in most of these patients, or?
Well, it's my basis, right?
Mm.
It's my groundwork. I'll start with that. And then if we have residual symptoms, then I'll start looking at other reasons for those symptoms. If those residual symptoms are gassiness and bloating, then we got to look in the fermentation department. What else is fermenting, right? And if someone also has sinus problems, chronic sinus problems, then I'll be like, you know what, we got to run this test because you might have some mold on board and it might be in the sinuses, and you might have also how hard is it to ingest a mold spore? Pretty easy, right? I mean, we're literally sitting in a cloud of them right now.
Yeah,
So
yeah, in
go immune
Seattle.
system,
I
right?
don't I don't miss Seattle, but we had massive floods here too. We had massive,
Yeah.
massive floods. So mold is pretty much everywhere. But
Hmm.
so this lab that you mentioned can be like sort of location specific for sinuses. I thought we always have to do sinus swabs, and it's hard to get them in the gut. No one tests for aspergillus in the gut, for example, that to my
Hmm.
knowledge.
So it's an indirect test for mycotoxins. So you know if
Mm,
you are having active IgG and IgE antibodies to mycotoxins,
I see.
then the problem could be inside the body. And it's going to be either sinus or digestive because those are the only two places that can really harbor a mold spore. And those guys are really smart, right? They're going to just hang out in there and wait for some immune compromise to happen, and then they can actually go ahead and have their families and set up camp. But those are two perfect places, the sinuses and the gut, because they're dark, they're warm, they have a food source, and they're separate, right? They're separate from the outside world. You can't get a sinus swab from the nasal cavity because you've got that tiny little channel between all of the four sinuses and the nasal cavity, right? And if someone has a fungal problem, that's clogged up. Just
Mm,
like our eustachian tube gets clogged, from the middle ear to the back of the throat. So if you stick a swab up someone's nose, you're going to get what's in the nose, but highly unlikely you're going to get what's in the sinuses. So then we're faced on either doing an indirect test, which is not the best, thing, but it's all we've got, or sending them to an ENT and hoping they'll culture it. Highly doubt that's going to
mm.
happen.
We use the uh, it's called what is it called? I can't remember now, but it's a lab
The
that where we
Marcons,
it does do Marcons also, but
my
it does.
microbi,
Yeah, I think so. Like my microbial diagnosis or
yeah,
something, diagnostics.
yeah, they're in
Uh,
Boston.
yeah. So we do try to jam it up as far as possible,
You
and
just you just can't get it in the sinuses. And do you get Marcons coming up for that quite a bit on
yeah,
people?
yeah.
Yeah. So I think that Marcons is actually a marker for the for the underlying fungal problem.
Well, that's
Because
what
I
they're
kind of,
saying. Yeah, we're
yeah,
using that as an alternative. That's
yeah,
part of the
yeah,
shoemaker protocol,
right.
But we digress. But it's it's so fascinating. I mean, because mold is so relevant, and also as climate is warming, as we're getting more extreme weather events, I think mold is going to be a major health factor, and so we need all
Hmm.
the treatment options and treatment approaches that we can have. Now,
Hmm.
what about the treatment steps for you? Like with you mentioned that you start with a low dose MSM, and then because MSM is so widely available, we used to use it for joint pain, right? I remember using it 25 years ago for osteoarthritis, as part of the cartilage sort of rebuilding efforts back then. But now we're using it, it's very freely available. And so I think a lot of listeners will want to experiment a little. It's very safe to use, in my experience with MSM. Is there a sort of steps to look out for, or any sort of advice you can give?
Yeah, so I'll go through the protocol that I use. It's quite simple, but there's a couple things I do before I start dosing the sulfur. And it's interesting because so the first thing I want to do is when I do my GI intake, I want to know, are your bowels moving, how often, all the basic things, right? Bloating, abdominal pain, reflux. If someone's constipated, I'm going to work on that piece before I do anything else, because oftentimes people think they have an overgrowth because they're bloated, and that's fermentation, but they're bloated because they're not moving their bowels enough, right? So we get the constipation off the table, and suddenly we don't need to do any treatment because that was the problem in the first place. So I always get the bowels moving first. What's interesting about this formula is that it is a bit of an alternative, is all I can say right now, in the sense that it helps with diarrhea and it helps with constipation. So when you have those people who are alternating back and forth, it's very helpful in terms of that. I just talked to an ND last week who was kind of in a similar place that I was, right? I tried all the things, really didn't have much change, and he ordered the powder from me and started doing it on his own. And he said, also, this is the first time the needle is moving on my symptoms. And he was a chronic diarrhea patient. That always surprises me. It must be the anti-inflammatory part of the MSM, acting in the gut is what I'm thinking. So first I get the bowels moving, then I remove the inflammatory foods,
Oh
which
yeah, we got to
my
circle back
group,
to that, right?
let's
I
do
have I
that.
have my own list, right?
Okay,
I wonder
so
if it's the same.
it's probably very
Yeah,
close.
yeah.
It sort of seems to be like when I go to any of the functional meetings now, everyone's all like, this is the group of foods, just don't eat them. So cow dairy, wheat, whole eggs, and sugar, those are the top four that I'll take out of the diet. So I'll either completely take them out while we do this, or I will have someone eliminate and challenge them, or I'll try and do a test and see if we can figure out, what is causing inflammation in the body. So any of those three approaches. That's not to say I haven't done this treatment without removing those foods and still been successful. But what I like to do is take the foods out, get the problem resolved, and then add them back in one by one, because if they're still inflammatory, it'll be very obvious. Right? If you systematically add them back in one by one, so you have a whole bunch of cow dairy one day and wait for 2 days and you end up, in the bathroom, it's like cow dairy is not your friend.
Yeah.
And if you keep on eating that, then you probably will end up back, in the same place with some kind of overgrowth or some kind of problem. So then I will also, in addition to that group of inflammatory foods, I will also, for people who are really, really in pain, a lot of pain, I'll remove the raw foods for a while.
Yeah.
I'll have them cooked, have really well cooked foods. I will also, if they know it's a problem, remove the crucifers, the brassicas, the allium family, and the legumes, just because they're so so easy to ferment, those guys. Like, even if you don't have any problems, right? If you sit down and eat a head of cabbage, forget about it. You could be the healthiest gut in the world and you're gonna notice it. Yeah, so that's basically what I do to just set it up for success. Even if it's maybe not necessary for everyone. And then I'll initiate the sulfur treatment, and I'll start with a half a teaspoon, which is 2.5 grams for an average patient. For someone really sensitive, I'll do that pinch dosing. Then I'll always assure them you could have a die-off reaction because we're killing yeast here. So you might notice that you feel more fatigued, or you have more body aches, or you have headaches. All of those things are normal, and they mean we're on the right track. So it's okay. And also I tell them that you might get a little bit more gassy, and if you do, I want you to hold that until it resolves. It will. It might take 2 days, it might take 7 days, but you'll stabilize at the dose, and then you can go up in another increment. The same thing might happen again. Just ride it out. By the time you get up to the 15-gram dose, that won't be happening anymore. You will have acclimated to that information, that mineral information you're taking into your body. And then I'll send them off, but I want to see them in 2 weeks because they're going to forget all that, because that's not their job, right, to remember. And so there might be things that come up. And so I'll be able to go through that reassurance again and just cover those things and kind of handling questions that might come up. If I do get any rashes develop, then I'll absolutely add in the molybdenum. I mean, really the only enzymatic pathway that I can see that we're influencing in this case is the sulfite oxidase pathway, because we're not giving methionine, right? And methionine is what drives the transsulfuration pathway and all those other places you can get some SNP defects and maybe cause some problems. But we're not giving methionine. Methionine is an essential amino acid, so we can't make it. So you can't take that sulfur and make methionine and push those pathways, but you definitely can potentially push that sulfite oxidase pathway and end up with too much sulfite and then have some reactions from that.
And cysteine, right? Because so cysteine is very high in animal products, and so animal meat, flesh products, right? So that's very associated with high sulfur reducing bacteria and stuff. So and high hydrogen sulfide. Okay, that makes a lot of sense. And you I mean, that's really, I love the elegance of the simplicity of it, and
well, I've been honing it now for like 25 years, so yeah, I kind of got a handle. But that it is very simple. It's very simple. It's very natural. It's kind of almost nature cure.
Yeah, and it's that form of sulfur. Is that form of is MSM the most tolerable form of sulfur, and is what is it, methyl sulfonomethane, right? Is MSM
methyl sulfonomethane? Yeah, that's pretty much all we have in the nutrient world to work with, right? Elemental sulfur, that would be toxic at pretty low doses, whereas with MSM, I'll give you the conversion here. So in terms of toxicity, because we excrete it so much, right? We're going to have any extra sulfite oxidase going to turn the sulfite to sulfate, and we're going to pee it out. That's what happens all day long. So you really can't have an adverse reaction to sulfate. That's not compatible with life, right? You can't have an allergic reaction to sulfur either, because that's not compatible with life, right. But you can to sulfite, right? So getting that sulfite moved through the pathway is important. So you can have no toxic effects at oral doses of 8 grams per kilogram per day. So that means a 665 pound person can take 600 grams a day. And we're talking about 30, right?
Wow. Okay. Yes, big safety limit there. Excellent. Well, that let me see if I have any other questions. But generally, this to me makes a lot of sense. I'm excited for people to that have this sort of incessant bloating to have another option to try something that they haven't tried before in a safe way. All of the information about Dr. Janelle, as I mentioned before, is in the show notes. So go to the SIBODoctor.com and click on the podcast, and all of the information is in the show notes. Do you have any other little pearls of wisdom to share, Dr. Janelle?
I think if there's anything I would say, it's so important to work with diet, right? That to not go down just because someone is gassy and having GI problems, to immediately think that there's something that needs to be treated with an antibiotic, because oftentimes you can have food enteropathies, that inflammatory food enteropathy, where you get symptoms that really mimic an overgrowth or fermentation symptom. And that's another thing that I've seen is people coming in who have been tested, treated with Xifaxan, their symptoms persist, and then we go, well, what are you eating? And I go, well, I'm eating, eggs and cow dairy every day. Well, let's just take those out of your diet and see what happens. And suddenly it's all gone. So then I question, was it ever really a bacterial overgrowth problem, or was it always a food enteropathy problem? And just to go back to that, all the principles that we signed up for, right?
Yes.
25 years ago. Well, 30 years ago.
Yes, 30 years
Right.
ago. And when you were talking about being bloated, I thought that was just normal eating, Jeff's food in the cafeteria at Best Buy.
He did make good bread.
He made great bread, but there was there was a lot of farty food there. So, and sitting all those hours. So I thought this was just part of med school. But anyways, I do agree with what you just said, and I certainly don't think that everybody who's bloated has SIBO. That's been my whole message, is to demystify a lot of this automation that we think around we're bloated and therefore we have SIBO, or it's a relapse when you've reintroduced certain foods. And that's why I love naturopathic medicine, because it gives us so many other tools to work with and other avenues to look at as to why people are symptomatic. And there's a lot of, a big component on stress, and a big component of, other issues that are not related to SIBO at all. I mean, stress is related to SIBO, but there's a lot more than just SIBO, for sure.
Right. Well, everything's related to everything, but we want to find what the cause is. That's why we signed up for this type of medicine in the first place.
Very wise words to end the podcast with. Thank you so much for your time. This has been really great, and I think a lot of people will be optimistic, or will be excited about something potentially new for them. I could think of at least 5 patients right now that if I wasn't on a sabbatical, I would definitely try this out. But hopefully they're listening and they can get some ideas as to what to do if they're still bloated. Thank you so much for your time.
Thank you for having me.
To access the biphasic diet and the SIBO Success Plan, or if you're a practitioner and would like to become an affiliate, go to thesibodoctor.com. Thank you for listening to the SIBO Doctor podcast. We hope you find the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering. Thanks again for listening.